Morning, everyone. Thank you for your time today. I'm going to be talking about harmonization and performance measure development to evaluate credentialing, and it really is sort of a follow-up to the presentation that Rhonda and Muriel just gave to kind of flesh out some of the ideas that they brought forward. So I'll start by reviewing some of the barriers to harmonization of credentialing data and some of the limitations of our current approach that we've kind of talked about this morning. I will talk a little bit about the conceptual framework for credentialing research that was reviewed first by Robin and Jack, but from a different perspective, using this as a guide to develop a common data model. So we heard about we need a data model, and then how to use this to identify and develop credentialing measures. And then I'll discuss the promise of big data analytics for addressing data gaps and make some recommendations for policy research and practice. So there are several barriers to harmonization of credentialing data and measurement development, and we've heard about them this morning. You know, there are a multitude of groups involved in individual and organizational credentialing. There isn't a lot of agreement on what that means. We heard that a lot of credentials, these standards are minimum and voluntary. The data needed for evaluation comes from multiple streams. There's not one database. Existing healthcare platforms rarely are able to capture, store, and organize all these different types of data in a way that supports manipulation and analysis, and then the absence of a common data model. So these barriers, contribute to the limitations of our current approach. Mainly that it's not data-driven to the extent it needs to be, and we're unable to aggregate the multiple streams of this imperfect data. We've heard already today the EHR systems cannot reliably link nurses and other team members with specific patients. That's a barrier. That there's inadequate data available related to the nursing process, particularly intervention data that's in a structured coded format. And there's inconsistent availability of data from the multiple systems that we need so that we can control for factors that might influence, modify, or confound credentialing outcomes. So from the data perspective, there are probably at least two priority areas for action. One is we need to build a common credentialing data model that defines the data to be captured, how it will be used, how credentialing data elements relate to each other. And this is in response particularly to Roy's question this morning, tell us what data we need. So we do need to develop a common data model that identifies what is that set. We also need to identify existing measures and then develop metrics to evaluate credentialing and support creating linkages between credentialing and outcomes. So there are several advantages to first developing this common data model. A common data model would define the core set of data that's required to evaluate the impact of credentialing on patient, clinician, and organizational outcomes. It would also facilitate the standardization of the data that's collected and how we collect it. It would facilitate agreement on metrics, what data elements are needed to populate the metrics, the terminologies that are needed to represent those data elements. It would facilitate harmonization of the credentialing data, and once we have harmonization, it would support interoperability of systems, not just within an organization, but across organizations, which is really what we need to do. It's organizations and different industries that contribute these data. And so, you know, we looked a lot at this conceptual framework for credentialing research this morning, and I'm going to talk a little bit about how we might use this as a framework to build a credentialing research data model. So you all know that it's based on Donabedian structure, process, outcome. And it does provide, I think, a natural springboard for identifying the different data types that are needed in order to have a common data model and the types of data we need to develop measures. And so starting with standards, you know, we have currently, there's standards data in organizational and standards databases. There's lots of different standards. There's an agreement on what we should be collecting collecting, but perhaps we need information about level of education of nurses, accreditation status of School of Nursing that nurses attended. On the organizational level, in addition to the many organizational characteristics that we heard about this morning, we might also be interested in what are the meaningful use stage 1 and 2 criteria that have been met by this organization? Where do they stand on the HIMSS EMR adoption model? Then with credentials, again, there's lots of different types of credentials. The data related to credentialing sit in organizational and credentialing vendor databases. What are the data elements that we need related to the different types of individual and organizational credentials? And then once we understand what the data types are and what these data elements are, we also know who's going to be the steward of these data, who's going to maintain it and store it and make sure that it's in a way that it's structured in a way that we can harmonize and exchange. We also heard a lot about the intervening variables. Jack talked about the causal pathways. Here I'm focusing a lot on the process measure. So we've learned in our research that nurses don't consistently document their interventions, what they do. And if we are ever going to be able to measure the impact of nursing care on patient outcomes, we need structured coded data on every single phase of the nursing process. And so, we need to agree on what are these data elements, and again, who is going to maintain them, how will we exchange them. And then moving on to credentials, these data sit in EHR administrative databases and incident reporting systems. We have a lot of measures already, but many of them are populated by data that we can't get electronically because it's not consistently in a structured coded format. And so again, we need to think about what are the data elements, where do we want to start, what are the ones that we want to be interoperable and exchangeable, and who are the stakeholders that need to be involved in those decisions. So with this chart, it's just an example of how we might start to flesh some of this out. So developing a common data model would take large groups of stakeholders coming together and saying, okay, so what are the research questions that are a priority for credentialing research? And then based on those research questions, what are the measures that already exist that could potentially inform this research question? And where does this sit on the in the measurement framework, and is it a structure, process, or outcome measure? What are the data elements that are needed to populate the numerator? What about the denominator? What meaningful use standards currently exist that we could leverage to for these so that we have harmonization and interoperability? And then what are the current data sources? Who are this would tell us who the stakeholders need to be in order to achieve harmonization. So credentialing data really fits the description of big data in that for certain types of credentialing data, there's a lot of it. So Roy said earlier, we have a lot of data, just tell us what you want. So we have volume. It's coming from we're collecting it very quickly. It comes from a whole variety of sources. And in order to aggregate it, a prerequisite is we have to know that it's credible. And so a proposed big data approach to credentialing research might be to use the conceptual framework for credentialing research to first identify nursing sensitive and credentialing sensitive research questions and metrics, to then identify the independent and the dependent variables that are the associated factors, to identify the sources and to collect the data as we looked at in the previous chart. Then transforming and aggregating those data from all of the different sources, healthcare, organizational, credentialing databases, and other databases. And then using big data analytics for discovery, communication of patterns and trends to generate hypotheses. And then, if we do, in fact, have a common data model and harmonization, we would be able to conduct multi-site research studies for hypothesis testing. So what are some of the recommendations and implications of this approach? From a policy perspective, we do need incentives to establish information networks, both human and technological, that would support harmonization from these very diverse data streams that are needed for credentialing research. So there's multiple stakeholders and that are needed really to achieve harmonization. In terms of funding, we need funding for projects that will identify ways to fill the large-scale credentialing data gaps. We have many. One relates to this research credentialing data model, but also high-quality nursing process data, getting consistent structured coded data related to what nurses do. And then research. So leveraging big data analytics to aggregate and analyze data from multiple streams, perhaps making a requirement in the RFA that researchers include questions that link research findings to credentialing. And then for practice, ensuring that all phases of the nursing process are captured within the EHR, and that would be a collaboration between nurses and their EHR vendors. Oops. So that's all I have. Thank you for your time. And I want to acknowledge Drs. Judy Warren and David Bates, who I consulted in preparing this presentation. Thank you.
Thank you, Patty. Our next speaker is Nancy Dunton, and Nancy will be speaking on developing, testing, and refining measures of nurse-sensitive quality of care. Nancy is a professor at the University of Kansas School of Nursing and School of Medicine. She's also director at the National Database of Nursing Quality Indicators, also known as NDNQI. And Nancy will be speaking from the table, and I'll bring the clicker.